all the attendees of WinCar's e-class. It's a pleasure for all of us to have very august faculty today, including Professor S.S. Kothari sir and Dr. Divya Malikarjun, Dr. Deepa from Sri Chitra Institute of Medical Sciences. So we will be having a clinical case from Dr. Gautam Reddy, second year senior resident TM cardiology from AIMS Patna. And I think following that, Dr. Deepa would be having some discussion. And it's a pleasure for all of us to have Professor Kothari for teaching all the students and to us also. So can we start? Can I invite Dr. Gautam Reddy to start his case?
Okay, I thought Deepa will do the discussion and we will have some general interference.
Sir, he will present the case to you, sir. You can ask all the questions and.
All right, so let's go ahead. We'll do that. Asking is not a problem at all, no?
We are waiting.
So, I invite Dr. Gautam Reddy to start his case.
Thank you, ma'am. So, is my screen visible?
Yes.
Yes.
Good evening, everyone. So today I'm going to present the case which we have recently come across. He's a 14-year-old male resident of Bihar, 8th standard student, presented with a history of bluish discoloration of skin and nail beds since 3 months of age, and shortness of breath since 3 months of age, and recurrent blood in sputum for 5 to 6 months. So, history of present illness. The child was noticed to have bluish discoloration of skin and nail beds at the age of 2 to 3 months, as observed by the parents of the child. But there was no history of exacerbation of this bluish discoloration with crying or squatting episodes. Neither there was any squatting episodes. And the parents also noticed shortness of breath in the form of fast breathing and interrupted feeds around 2 to 3 months of age, associated with perspiration. And he was also admitted for chest infection at the age of 1 year, which was probably managed with mechanical ventilation and required 1 month of hospitalization. Over the years, his shortness of breath progressed a little, and now he has difficulty climbing 2 flight of stairs and riding bicycle for short distance, which mean to be NYH. He is in NYHA class 2, but there was no history of orthopnea and PND or lower limb swelling or abdominal distension at any point of time during the illness. There was also associated easy fatigability and poor weight gain. For the past 5 to 6 months, he also complained of episodic blood in sputum, 1 to 2 episodes per month, each episode having 10 to 15 ml of bright red blood mixed with clots. It was self-limiting and did not require any hospitalization. There was no history of fever, weight loss, or poor appetite or exacerbation of shortness of breath with this blood in sputum episodes. Coming to negative history, there was no history of recurrent chest infections in the childhood, although there was one significant history of pneumonia, and neither there was a history of loss of consciousness or tonic-clonic movements. There was no history of limb weakness, headache, giddiness, tinnitus, or decreased vision. No palpitations, no prolonged fever, no joint pain or swelling. Past history was not contributory. Personal history. He is a second-born full-term baby through normal vaginal delivery out of a non-consanguineous marriage. Siblings are healthy, and there was no history of congenital disease in them. And developmental milestones were achieved appropriate for the age and comparable to peers. He takes mixed diet and has normal appetite, and bladder and bowel habits are normal. Sleep-wake cycle is also normal. No history of food or drug allergy or substance abuse. Maternal history, there is nothing significant occurred during the pregnancy period in the mother. Treatment history, his parents were told that the child had a hole in the heart at 5 to 6 years of age, and they had multiple consultations for the same. And they were also told that he required a surgery, but the exact nature of the surgery, whether it would be staged or not, was not known to the parents. Socio-economic history: the family belongs to lower socio-economic status according to modified Kuppuswamy scale. So,
You want to summarize? Go ahead.
yes, sir. 14-year-old male with a history of progressive cyanosis, which was noticed at 3 months of age and had interrupted feeds and failure to thrive in infancy, and non-progressive shortness of breath of NYHA class 2 since 3 months of childhood, not exactly three months of age, and with a history of pneumonia at 1 year of age with poor weight gain in childhood and episodic hemoptysis for past 6 months, with a history suggestive of patient having congenital heart disease that requires surgery.
All right. So in the given time, we will try and catch up with some fundamentals, because so many things can be discussed. We'll
Yes,
not discuss trivial things, but we'll like to see what are the essential aspects of congenital heart disease patient, right? So
Yes.
to me, before we go into that, one thing which disturbs me, Gautam,
Sir.
3 months to 14 years is a long time.
Yes.
And you are so preoccupied with cyanosis and feeding difficulty, etc., that you really didn't tell us between 3 months to 14 years how life has been, whether he could go to school, whether and why no operation was done. It is obvious that they are poor, but you didn't spend any time. So I think doctor today needs more of a social dimension of the disease more than anything else. I would have been happy if you would have told me why the child has not been operated, how many times he showed. At 5 years, he was told hold in the heart, and till 14, nothing has been done. That is also a big part of history, no?
Yes.
So other thing besides, we must dwell into this. So what has been the life for the baby from 3 months to 14 years of age?
Yes.
Can you slightly elaborate on that?
Sir, the child went to school, sir, and when the hemoptysis episode developed, like from past 6 to 8 months, he had stopped schooling because of frequent hospital visits and shortness of breath.
So that's
Otherwise,
only now. That's only now.
Yes.
So was he okay in the school? Did he really could do his job in the school as other kids? Could he carry his bag?
yes, sir.
Hmm?
He was average at studies, sir. And
Because that will give me some clues to the type of disease. Man, did he have very bad disease, or it was a moderate kind of disease and he pedaled on normally? It's important to
Yes.
understand that.
Yes, sir.
So which of this is true? That he had very difficult
had-
disease, or he had a very mild, moderate sort of disease?
It's a moderate kind of disease only, sir.
So his growth and development has been generally not too bad, right?
Not too bad, but there was poor weight gain and perceptibly he's thin.
So early days you described early time there is failure to thrive, etc. But then later on you lost track of that part, no?
Yes.
So,
Gautam, and one more
Yes.
important thing is actually in the initial presentation I missed it, but you should have been mentioned the milestones separately. Like if 3 months to the 12 years, not telling about the milestones is not correct. I don't know whether you mentioned or not. And especially for a child, not only in the mental development, growth also, linear growth also has to be specially mentioned. And height for weight, height to weight, according to the age, has to be mentioned. The mother may not able to give so much detail, but you can ask them to compare with the contemporary children and say that whether he's along with them or not.
Yes, ma'am. The parents were actually not able to recall in detail, ma'am. But as far as I could gather, that there was a sibling, there was a child in the similar age group children in the neighborhood, and his milestones were comparable to them.
so not severe physical mental lag, right? So
Yes.
general disease. Okay, so does it suggest to you decrease pulmonary blood flow, increase pulmonary blood flow? What does
Sir,
the story suggest?
So the story suggested it is like it must be increased pulmonary blood flow to begin with, sir, because he had interrupted feeds and a failure to thrive and one history of pneumonia in the infancy. But in the other than that, there was no history of recurrent chest infections in the entire childhood. So that makes me think that probably EA pressures have risen over the years. But to begin with,
Okay, so no, early days there was failure to weight gain and some. So having one respiratory, one pneumonia, is it bad enough? Children without heart disease, don't they get pneumonia?
They do get, sir.
So then how do we define that this is, recurrent LRTI? How do we define, or when do we say recurrent LRTI?
Sir, when it is more than 3 LRTI episodes in a year, it is called recurrent LRTI.
So this child had one, but even one which is needing mechanical ventilation is pretty bad. So that could
Yes.
probably tell us. Yeah, I agree with you. But the cyanosis was noticed at 3 months of age, not at the birth.
No, sir. He is actually in dark complexion, sir. And
So one possibility is that it could have been missed. That's what you want to say?
yes, sir. The parents noticed at 3 months of age. Possibly they might have missed at the birth.
What are the other possibility? Either they could have missed it, or
it
in other words, how when does a cyanotic child does not appear cyanotic?
when actually when if he is to begin with, if he has anemia, then he doesn't, and the level of saturation also decides when the child becomes visibly pale, visibly cyanosed.
So that's a very important point. No? So let us discuss what is anemia for CHD.
Yes.
What is anemia for cyanotic heart disease? When do you say they are anemic? So how do we say that this cyanotic child is anemic? Is it like normal, or is it different from normals?
It should be different, sir.
Different, yeah. So what is the difference? You're right.
Exact cutoff, I'm not aware, sir, but
Your guess?
maybe less than 10.
Less than 10 is anemic for everybody, no? Less
Yes.
than 10 is anemic for a normal child also.
Yes.
So 10 is bad. 10 is a bad guess. So it will vary with saturation. A rough rule of thumb is anybody with 85% saturation or who is visibly blue should have hemoglobin of 14. So somebody with 60 saturation should have hemoglobin of even 17, 18. There is some formula also. But broadly, this will be okay. Anything less than 14 is certainly not a good thing. Right? And worse the saturation, more the hemoglobin needed. So that is one part of it.
Okay.
Now, so he could have been anemic, maybe, or maybe could it be that the cyanosis began at 3 months? That actually cyanosis became obvious by 3 months.
It became obvious by 3 months, sir.
What disease could it be like that? What kind of disease where you can become cyanosed by 3 months and you increase pulmonary blood flow?
In the
what sort of disease you have in mind when we say cyanosis noticed at 3 months of age? Maybe it was there earlier and child has increased pulmonary blood flow.
It could be, sir, all the admixture physiology disorders like DORV with VSD. And
so either admixture physiology or a transposition physiology.
Transposition physiology.
Yes. One of the two, right? One of the two. If our impression is correct. So you should fall into one of these two. And there are many, the different varieties we can't say from the history, but maybe it is like that. Then the problem only is if it is admixture, why it was not obvious in the beginning. When do the child with admixture physiology become blue?
So it should be right from the birth only, sir.
Isn't at birth, no? So what happens to them in next 2 months?
In the next 2 months, there will be increased pulmonary blood flow, so they might be, they will become, they will catch pneumonia easily and frequent LRTS NCU.
What happens to cyanosis?
Cyanosis, it also
as the pulmonary blood flow increases, what happens to cyanosis in admixture lesions?
So actually, that it won't change much, sir.
It could improve actually, because as the pulmonary blood flow become better with PVRI going down, they might really look a little better in terms of cyanosis also. Because admixture flow, eventually cyanosis is determined by what?
If the pulmonary, the dissolved oxygen content and the pulmonary venous
Pulmonary blood flow in general. So as the pulmonary
Yes.
blood flow become more, because admixture is going to happen eventually. So somebody with 4:1 will be less cyanosed than somebody who is 2:1 or 1:1. So
Yes, sir.
it is really possible that cyanosis become less. So suppose there is a story of a baby who was very blue at birth and become less cyanosed by say 1 month. What are your options?
It could be
Opposite of what we normally worry about, very blue at birth and quite okay by 1 month. Best possibility.
hmm,
Typically, this is the story of an Epstein anomaly. When is the Epstein baby his worst? He's worst on day 1. If an Epstein has survived 7 days, he can survive next probably 70 years or whatever. I mean, so he becomes much and much better as the PVRI goes down. Correct?
yes.
So what is the normal involution of PVRI? When does that happen? When does a neonate becomes like an adult PVRI?
By 2 months of age, by 6 to 10 weeks, sir.
In normal versus somebody in VSTs.
In VSD, it is 6 to 10 weeks, sir.
Right.
And
so normal is going to be bet more than that or less than that?
it should be even less only.
Less only, isn't it? So normally, this is not realized. Mostly people make a mistake in this. Normally, it doesn't take 2 months to get to low PA pressure. Normally, in a normal baby, it becomes quite fine, quite quick. Within a week or so, it's touching nearly adult PA pressures. Whatever, I mean, the infant PA pressures, if not adult. All right. So, and so now we have somebody who is, so you're thinking that he developed some pH, therefore he grew okay, and then he had some hemoptysis from whatever.
Yes.
So other possibility, could he have developed PS?
PS, to begin with, he didn't. There are, at this point of time, I can't rule out that possibility also, sir. That decreased pulmonary blood flow also could be a likely possibility in this case, but less likely.
So when a baby improves, like either he developed PH or he developed PS, or he had a natural regression of something else, whatever third thing, isn't it? So all possibilities are there. We can't really be very sure. But only thing we know is that he probably did not get into heart failure. Is that right?
Yes, sir.
He grew nearly okay, so he didn't develop heart failure. So he probably must have developed either of these, PH
Yes.
or whatever. Unfortunately, he was not operated, and we don't know the details, what type of surgery, etc. So that we'll see from examination and from other things.
Yes.
Yes, Dr. Josna, any other questions before we can go to exam? Any other questions from anybody else? Can you hear me?
Yes, sir, we can hear you.
So
Yes, sir.
shall we go to examination then?
I think
Okay, let's go to examination.
Yes. So on examination, child is conscious, oriented, cooperative with a thin build and a BMI of 14.8, and it is less than 1%. He stands at 1% also for the BMI value, and vitals. It is pulse is 90 per minute, regular, normal volume, has normal character. All peripheral pulses are symmetrically palpable. Arterial wall not palpable, and there is no radial or radiofemoral delay. Blood pressure is 98/60 in right upper limb and 100/63 in left upper limb and 110/70 in the right lower limb, and comparable on the left side also. And respiration, it is 18 per minute regular abdominothoracic. He is afebrile to touch, and saturation, it's 78 in bilateral upper limbs and 80% in the right lower limb.
So is it significantly different or not significantly different?
Not significantly different, sir.
So what is the significant difference?
For saturation, it is I came across 2-3 values, sir, at different places. At one place they have written 5, and in others they have written 10.
No, 10 is nowhere written 10, but people have written 3 or 5. 10 is way out. Nobody says 10. There is a difference between 3 and 5, but maximum is, I mean, the best is probably 3%. when you, in a newborn, if there is a gap of more than 3, you start thinking of some disorders, which can give you
Yes.
differential saturation. So differential saturation for a newborn screening is taken as 3%, right?
Okay.
10 is way out. 10 is there is a terrible, some real clear issue. Now tell me one thing, you have this from oximeter, right?
Yes, sir.
So is it more reliable value or a blood gas is more reliable value?
Blood gas should be more reliable, sir.
So we have saturation from blood gas and we have saturation from oximeter. Which of it is more reliable?
If sampling technique is right, then blood gas should be more reliable.
So what is the difference between the two actually? If there is any difference, if you think there is a difference or there is no difference. So mostly you see this is really measured. This is measured by different light spectra, whereas the blood
Yes.
gas is extrapolated value from PO2. Blood gas doesn't measure saturation. Some recent blood gases do that also. But generally blood gases don't, they extrapolate saturation from PO2. They have a PO2 and they have some standard curves, etc. So saturation by oximeter is more reliable than saturation by blood gas. PO2
Okay.
of course is not measured by saturation. PO2 is measured only by blood gas. So PO2 is a little different, but saturation, this is a very reliable. And what is the kind of this instrument is a 2% standard deviation. So up to 2% we don't mind. So beyond 3% we think there is something which needs to be sorted out, and 5% is a clearly different thing. And of course, the causes of differential cyanosis and reverse differential cyanosis, etc. Right?
Yes.
Okay, go next.
He has uniform central cyanosis and grade 2 pandistal clubbing. JVP is normal with normal waveforms and negative for hepatojugular reflex. No pallor, icterus, pedal edema, or generalized lymphadenopathy. No dysmorphic facial features. No peripheral signs of infective endocarditis, AR, or acute rheumatic fever. And dental hygiene is normal. So coming to systemic examination on
anybody who tells me about dental hygiene in a cyanotic child, I will pass him, no matter what else he says, because that is such a big gap, and people really don't give an importance to that. And what all do you see actually when you say dental hygiene normal?
caries tooth and gum diseases.
Because the thrust is on gum, thrust is not on caries actually. It is how healthy gums are, because that is where the game of endocarditis and other things. So gum health is important, and we not being dentists, we really don't understand much of it, and we don't even ask them to open the mouth. But this is very good that you look at the mouth. Go ahead.
Yes. So on inspection, the tracheocentral chest shape is there was precordial bulge, and apical impulse is seen lateral to midclavicular line below the nipple, and parasternal pulsations were seen in left, second, and third intercostal space, and epigastric pulsations were also visible. There were no suprasternal pulsations, no visible scar mark or sinuses or dilated veins. On palpation, the findings of inspection are being confirmed. Apex beat felt in the fifth intercostal space, 2 centimeter lateral to midclavicular line, sustained and in character, and second heart sound was palpable, and grade 2 parasternal heave was present, and epigastric pulsations were felt at the tip of palpating finger, and there was no palpable thrill.
Probably you should try to tell us it's a RV apex or LV apex.
It's RV apex, RV type of apex.
So how did you come to that conclusion?
Because it is only shifted laterally, not downward.
It's not a very reliable thing, but you should.
And also the parasternal pulsations, which I felt, sir, they were continuous with the apex.
So retraction should also be mentioned, medial retraction or lateral retraction. Yes. That will make the point. Once the minute you say retraction is medial or retraction is lateral, that will put the money on RV or LV. So that would be good if you put it there. All right then.
Okay. On percussion, the right heart border is 2 centimeter beyond the right sternal border.
Can you have, sorry for interrupting, can you have heaving apex if it is a right heart, if it's a RV?
Yes, ma'am, in case of RVH.
Sir, what do you think, sir?
I wouldn't have much problem with that. But see, apex is such a difficult thing that no two examiner will agree on your things. But I would be okay if you classify it as heaving RV. I don't think it cannot be heaving apex.
Okay, sir.
If somewhere somebody has written, Abraham has written something like that, I don't know. But what do you say?
No, I don't know, sir. Usually heaving apex, we usually associate with LVH. That's why I asked.
That is because when it is retraction is medial, it's LV. Once there is a lateral retraction, it's RV consistent with the parasternal heave. So let's say somebody has severe pulmonary stenosis, he probably can have heaving RV. Entire apex is made by RV. Okay.
Okay, sir.
Percussion, right heart border is 2 centimeter beyond the right sternal border, and left heart border corresponds to apex. And left intercostal space, second intercostal space is dull. Liver dullness was felt in the right fifth intercostal space in the midclavicular line, and liver span is 12 centimeters, and trop space is resonant. Coming to auscultation, S1 is normal, and S2 there is a loud P2 with fixed split. It was not wide enough, sir, but there was fixed. And there was a high-pitched grade 2 end diastolic, early diastolic murmur heard in the second intercostal space along the left sternal border, decreasing with expiration and increasing with inspiration, and best heard with the diaphragm of the stethoscope. And another holosystolic high-pitched blowing murmur of grade 3, 3/6 intensity was heard along the lower left sternal border with Carvalho sign positive, best heard with diaphragm of stethoscope. There were no other sounds or murmurs heard. And other systemic examination was within normal limits.
So no S3, no.
So, yes, sir. No other sounds were heard.
Okay. That's respiratory system normal. Abdomen is.
That's right.
So let's see murmur again. There are two murmurs, right?
Yes,
One
sir.
is high-pitched grade 3, and the other is a holosystolic high-pitched blowing. All right. So what's your diagnosis?
Sir, based on these findings, I like to keep a possibility like there is it's cytosolitis leocardia. There is congenital cyanotic congenital heart disease with increased QP with Eisenmengerization, Eisenmenger physiology with severe PH, no PVH, and sinus rhythm, and in NYHA class 2 without any infective endocarditis or complications of cyanosis.
Okay, before I give it to Dr. Deepa, this is a little bad thought, because once we say Eisenmenger, we know is not operable. So from these findings, could it be an operable situation?
Sir, since the saturation is 78 and there is loud P2, and the age is also almost 14, so
when can you be 14-year-old loud P2 and operable patient? What disease you can have loud P2, about 80% saturation, and still operable? It's a oblique way of asking question. We try to rule out operability first, because once we can't, then once we diagnose Eisenmenger, then we are lost.
yes.
Ram Charan is saying congenital MS, so that's a great thought. No, only thing is why isolated MS will not be blue, so therefore we didn't think of MS as such. Why should MS have a saturation of 80% unless you say is in pulmonary edema? So your findings are not fitting with this diagnosis. What is the thing which is not fitting with your diagnosis? Does Eisenmenger have a grade 3 murmur, ejection murmur? You described a loud ejection murmur.
So ejection, early diastolic murmurs.
No, systolic also, no?
Or, this one, yes.
There is one EDP, there are two murmurs, no?
Yes, sir.
So both are diastolic murmur?
No, sir.
One is tricuspid regurgitation murmur. You meant
You are saying PH and TR only.
PR and TR.
So there is a TR murmur which is holosystolic, and there is a PH murmur. Okay.
PR murmur. Actually, I could not appreciate the ejection systolic murmur of the pulmonary area, sir.
So there is no ejection murmur. I thought you were saying this is a ejection systolic murmur. So this is a diastolic murmur only.
Yes,
So
sir.
fine. So your systolic murmur is only a TR murmur. That's what you say.
Yes, sir.
Okay.
And also the tricuspid flow murmur is also not there across the tricuspid valve. That also is a that also points out towards inoperability.
So Carvalho sign positive is because of what?
Because of
I mean, why there is Carvalho sign in TR?
because with the inspiration the chest the intrathoracic pressure decreases, so it will accommodate more blood, so the murmurs on the right side exacerbate.
Some better explanations are there, but anyhow, we'll leave that. So, can you have a loud P2 without PAH? When do you have a P2 which is loud, but there is no PAH?
So in hyperkinetic pH, that also is pH.
Hyperkinetic pH, that is true, that also gives you loud sound. It is said that in AST patient, P2 loudness does not correlate with the PA pressures. So that is one setting where loudness, it should not go by loud P2 because all ASTs will have loud P2, even when they are operable or even when they are not operable. So just as a caveat. And suppose somebody is bilateral peripheral PS, so he must still be operable, but his P2 will be loud. So that's of course kind of exceptions. So possible lesions which has given rise to this.
Can just one doubt in the diagnosis slide.
Yes.
You have written increased QP with isomegarization. Is there any condition that can have increased QP with isomegarization? It is possible, but which condition are you particularly thinking of with increased QP and isomegarization?
Ma'am, I mean to say to begin with, it was increased QP. Then isomegarization has occurred, like admixture.
You meant cyanotic heart disease with increased pulmonary blood flow, which has gone on for pulmonary vascular disease.
Yes, ma'am.
Okay. So what happens to the QP once it isomegarizes?
It decreases, ma'am.
Yeah, it reduces. Can you say any cyanotic heart disease where you still continue to have increased pulmonary blood flow?
Even with isomegarization.
Yeah. I mean, to begin with itself, it is severe cyanosis, but there is increased pulmonary blood flow. Baby can come with a saturation of 40%, but when you take an X-ray, it looks like increased QP.
Like obstructive TAPVC.
That is pulmonary venous hypertension. So increased pulmonary blood flow with very severe cyanosis. That very severe cyanosis is the clue. So yeah, in TGA, you can have increased QP because there is no control of autonomic nervous system in a TGA on the pulmonary vasculature. So you will have increased QP even if there is no VST or PDA.
You understand that, no? Because the TGA child will on X-ray will show increased pulmonary blood flow, even there is no AST, I mean no VST, no PDA. Right?
Yes.
This point worth keeping in mind because many people think that when there is no VST or no PDA in TGA, QP will be normal or low. It is not like that. It is certainly increased. So that is one point. So wide fixed P2 and this. So what is the PA pressure likely?
Since his systolic blood pressure was
can you tell PA pressure from physical finding?
Sir?
From murmur of PR, can you say PA pressure? Could it be a normotensive PR? The absent pulmonary valve. Patient is PR because he has absent pulmonary valve and he has some whatever.
It should not be, sir, because we have heard loud P2.
Loud P2, I tell you, AST with absent pulmonary valve. We'll have loud P2 and normal PA pressure. From the murmur itself, you can say it is not a normotensive PR murmur. Because the normotensive PR murmur, the type of murmur you see in absent pulmonary valve is a medium frequency murmur. No? This high frequency blowing early diastolic like AR murmur just puts the thing on high PA pressure. When you confuse AR, PR, they're similar like sounding murmurs. They are high PA pressure. They are not a normal PA pressure. So if you're very clear the murmur is like that, then you can put your foot down that no matter what, there is PH here. But suppose I say it's a AR murmur, it's not a PR murmur.
Because of the area where it is heard maximum, I decided.
Discriminate because they are very nearby. AR PR area will not be a good distinction point.
And also associated findings of loud P2 and partial pulsations.
But AR patient is not immune from getting PH. He might have PH from something else, but this murmur is AR murmur. That's what I am contesting. Why this murmur is not AR murmur?
One thing is the inspiration, it was increasing, sir.
Okay, so one thing inspiration increase, but this is a soft sign, no? I mean, one may get confused. What are the harder data to say that this is not a AR murmur? Inspiration is important one, agreed.
And
cardiologist is increasingly finding difficult to talk of pulse, because he's busy with MRI, LGE. What about pulse pressure?
Pulse pressure was, it was 96/60, 38 or
low pulse pressure. I mean, it's not a pulse pressure of a AR. If
Yes.
such a nice murmur is there, you would expect a bigger pulse pressure.
Yes, sir.
But that was not the original question. The original question is, when do you have a wide pulse pressure in absence of AR, or rather from PR? When you have pulmonary regurgitation but a wide pulse pressure? The murmur is a pulmonary regurgitation murmur, but then the patient is a wide pulse.
MAPCAS, there are MAPCAS when there is when there are MAPCAS, then it will cause bounding pulsations and with the presence of PR.
It's possible that somebody has such MAPCAS, it's a wide pulse pressure because of that, and there is a murmur of PR. Okay, no MAPCAS. Vishwajit is answering that because he is probably. So these are typical. There are 3-4 googlies in congenital heart disease. This is one of them. So this is patient of Eisenmenger, PD Eisenmenger. When there is a PH PR, because there is a PDA, PR will manifest on the periphery as AR, right?
Yes.
When the patient is PDA, PH, PR, it is a wide. He or she has a wide pulse pressure. So unless you factor that out, sometimes in Eisenmenger you can get stumped.
Yes.
So what lesions you have in mind? This is not complete diagnosis. You have to say some lesion which is causing Eisenmengerization, no?
So,
Yes.
what about the cardiomegaly? How can you explain the cardiomegaly? So usually when Eisenmengerization happens, the cardiomegaly regresses. So if the cardiomegaly persists, do you want to think of something?
In other words, when Eisenmenger has cardiomegaly,
Yeah. Yes, ma'am. I also agree. Like Eisenmenger also has at least RV type of epics.
cardiomegaly, mostly VST PD, do they have cardiomegaly or no? Let's get it straight. Do Eisenmenger have cardiomegaly or no?
Yes, sir.
They have VST Eisenmenger, PD Eisenmenger. Generally will not have cardiomegaly because why they don't have cardiomegaly? By the time there is no increased QP, by the time they are Eisenmenger, there is no increased QP. Overall heart volumes are not high. So why should they have cardiomegaly? So VST PDA, you will not find cardiomegaly. But that's what Dr. Deepa is asking. So pre-track aspect, because of time, we will probably not prolong it. So AST is Eisenmenger will have cardiomegaly. This is one distinction between AST, VST, PDA, cardiomegaly, the standard question. How to distinguish Eisenmenger, AST, VST from and PDA? So one of the important factors is cardiomegaly.
Oh.
And there may be some other causes. Yeah, anything else, Dr. Deepa, you would?
No,
I
sir.
think so.
You can go ahead, sir.
Yeah, we are running out of time, so let's go to investigation and catch up with something more important. No, before we go, so you have to say which lesion is causing Eisenmenger. So I see AST Eisenmenger, it's PD Eisenmenger.
Because ASD Eisenmenger, so because of the fixed split, and there was cardiomegaly.
So when did he become Eisenmenger? Eisenmengerized, because he was blue from 3 months of age.
Yes, sir.
So did he become Eisenmenger at 3 months?
No. Because at the 1 year he had pneumonia, so probably might not have become Eisenmenger till then.
What is the disease that you are dealing with? From your total story,
Yes.
cyanosis at 3 months, probably increased blood flow, becoming PH later on, and white face second heart sound.
Probably it is the pre-tricuspid mixing is happening. So TAPVC should be a possibility in this case, sir.
Excellent. I would think a TAPVC or a common atrium, that kind of thing. If all your findings are, I mean, if you agree with all the findings, then you should consider pre-tricuspid shunt and Eisenmengerization, which may be, but then there is a problem because pre-tricuspid generally don't get Eisenmengerized so early. So we are against the issue. So could it be TAPVC with additional lesion, because of which he has become so early Eisenmengerization? TAPVC could account for the early cyanosis, and other things can, for example, AV septal defect, as Abhishek is writing. It's possible, that he has a more complex lesion, because in AST TAPVC you wouldn't expect by 14 to be Eisenmengerized. So because since there is no ejection murmur at all, and you are reasonably certain that there is serious significant PH, PR, so either it's a TAPVC, one of the ones which uncommonly gets Eisenmengerized early. TAPVC can get, it's not that they do not, but very often you find 14, 20, 30-year-old TAPVC is operable. Or there are other causes of AST with cyanosis. Which are those causes of AST with cyanosis in absence of severe PH? This may be the last concept that we cover. AST blue, but not PH.
Tricuspid atresia.
But that's a tricuspid atresia. We don't call that as AST. No? Come on, your friends are answering it quickly. You have to be quick, Gautam. So let us imagine a child with AST who is operable, but he is blue. So DD.
Yes.
Differential diagnosis of ASD who is still operable, but is blue.
Associated LSVC.
Excellent. But not LSVC. You have to say unroofed coronary sinus. LSVC will drain into coronary sinus and RI. That won't give you blueness. So unroofed coronary sinus, that is LSVC opening into LA, or a common atrium, because it's a common mixing sort of situation. Or there are about 7-8 causes.
A PAPVC.
PAPVC is a cyanotic heart disease. PAPVC does not give you any cyanosis. A TAPVC masquerading as AST could still be operable in blue, and they have an AST all right. So TAPVC possible. A large eustachian valve directing the flow from IVC to LA, right? So they can be operable and still they look blue. Sometimes after pneumonectomy, sometimes after aortic, large aortic aneurysm directing the flows, etc., etc. So some of those. Okay, let's see X-ray ECG quickly. Is that the part of the game that we'll see X-ray ECG?
Yes. Yes. So this is a ECG of the child, sir. It is showing RVH with strain pattern.
RVH with strain. Okay. So suprasystemic RV or systemic RV or subsystemic RV? Suprasystemic RV.
Because of strain, we can
guess that. You can hazard a guess. You may be right. Nothing in particular more. No. Let's go to X-ray.
Sir, actually, X-ray of the child, we could not collect the.
It's okay. This is a reasonable X-ray during CAS.
Yes, sir.
What is it showing? You should have had a full film actually. This is giving you the.
Yes, Snowman sign is visible on the X-ray. So TAPVC.
You have hemodynamic data?
Yes, sir.
Can you share that? Because
this is a picture.
Which catheter is that? What injection is this?
Sir, sorry. Pulmonary artery injection angiogram was taken, sir, and MP catheter This is JR only.
So should you do an angio with JR?
No, sir. But we should have taken Swan-Ganz, but it was not available at our center.
You do angio with the Swan-Ganz?
Not angio.
You are showing me an angiogram.
Yes.
You can't do an angiogram with the endole catheter. But you say I just did a hand injection just to show something. You can do a hand injection, but you should not really do it. Technically, you should not do an angiogram with the endole catheter, right? You know why you should not do?
The jet might injure the wall of the vessel.
It's just showing, probably just showing structure, just a hand shoot to make sure that you are in PA, not in coronary sinus or something like that. That can be done. Yes. But remember, you do, okay, just by the way, how much pressure you give for injection when you do an angiogram?
With the power injector, 30 psi.
You are alone in Patna and the technician has gone on leave. Then sister will ask you, chalo kar dete hain. How much pressure? That you should know. But another more important thing, one more error, I should say error only just to emphasize the point. In a patient of PH, you never do a angio like this. PH patients are terrible. You will lose a patient of PH on cath table someday. Because PH is not something, is PH you to fear like you fear LMCA. You know, so especially when there's PAH, PR, very blue patient, you must not catheterize them unless you want to have something really important. Number one. Number two, if you must catheterize them, you must do pulmonary artery injection 1 and 2 separate. So that one lung is okay, one lung is getting injected. And inject low pressure, understand everything, not make them hypoxic. So PA angio in a Eisenmenger can be a last straw on the camel's back. So let me scare you even more. Don't catheterize an Eisenmenger unless there is something which you want, unless it's going to change something. Unless the diagnosis is doubtful. If the diagnosis is doubtful, go by all means. And if you become good at all that, you can do it. Every PH patient, they say should have one cath, but then it should not be done like we do coronary angios. So this is suggesting TAPVC. If you had pressures, we could just quickly talk about that. Is it operable? Yes. Not operable after pressures?
Not operable, sir.
So let's have a quick look at those. 90 IVC, what is the aortic femoral artery is 82, and calculated PVRI is?
So, actually, we
may not be operable actually, yes. But calculated PVRI, you not calculated PVRI?
No, sir. Actually, we could not get a pulmonary venous sample.
That is the easiest thing to do here. You are into pulmonary vein. You didn't go to the main pulmonary vein?
No, sir.
Common pulmonary vein, you can go from SVC itself. That should have been very easy. So it is a TAPVC with Eisenmegerization and inoperable at 14 years of age. Unfortunate. PA pressures are, where are we? At 60 mean with a saturation of 86. And aortic is also 82. You should have probably given some vasodilators also and see what happens to PA pressure, what happens to saturation. Maybe you can give him oxygen in the ward and see what happens to aorta. If the aorta touches 90, I would really think twice before declaring him inoperable. Or if you're finding
aortic saturation.
If you have an echo, maybe Deepa can also look at the echo and tell you if operable, inoperable.
Actually,
a significant step up, I was thinking, sir. IVC is 65. They have not mentioned the low SVC. High SVC is 90, but RA is 83. So if you presume good step.
That's right. So there's slight suspicion about the inoperability part, So you have to give a good look, maybe do a bit of vasodilator. But I won't be surprised if he's inoperable. But I would be happy if you had a little better data, because see, 85 in aorta in TAPVC is operable. As a rule of thumb, 85 plus TAPVC is always operable. So this is 82, and he's only 14 years. And in TAPVC, this is, I think, listen to this point. In VST and PDA, when you operate, you are changing the physiology, you are changing the contractility of the heart. In a TAPVC, you're not troubling the heart. RV is going to do the same. So in TAPVC, your threshold for operability may be even high. That means maybe low. Means I would like to operate a TAPVC even if the PVRI is in an inoperable range, little higher. If other things are suggested, if there is a good step up, I would do a fenestrated AST closure and operate TAPVC. So this child, I'm not very, very sure whether it's inoperable. I would do a recath with perhaps SVC, high SVC, and some vasodilator testing. And then some suggestion is there, then I will go for a closure with a fenestrated AST closure. That's enough. So Gautam, I think you did well. And I hope there are some concepts we covered, and I will hand it over to Dr. Deepa for more clarifications.
Thank you, sir. I was asked to make a very short presentation on approach to cyanotic congenital heart disease.
Yeah.
So, shall I go ahead?
Yeah, I think we
Yes, sir. So I basically started off with cyanotic congenital heart disease in the newborn. So cyanosis, of course, is very difficult to pick up. Sometimes it's very environment dependent. A lot of things may skew the diagnosis. We have to understand that there are critical and non-critical cyanotic congenital heart diseases, and we have to be very particular that we should not miss any critical cyanotic congenital heart disease. And they are transposition of great arteries, duct-dependent pulmonary or systemic circulation, obstructed TAPVCs, critical Epstein's anomaly. There are other non-critical ones where CCHT with increased pulmonary blood flow like admixture lesions, or CCHT with reduced pulmonary blood flow like non-severe TOF or TOF physiologies and unobstructed TAPVC. So this patient that you presented was probably unobstructed TAPVC to begin with. Then, so what should you suspect when the pulse oximeter falls, depending on when your cyanosis is, the baby develops cyanosis. So within 0 to 3 days, that is when the transitional circulation happens from the fetal life to the newborn life. So then when cyanosis develops in that period, you should think of parallel circulations or critical obstructions. So parallel circulation
To
happens.
interrupt, Deepa, your slides are not seen. Okay.
Oops. Oh, sorry. Now, madam? Now is it visible?
Yes, we can see your slides now.
Okay, thank you. So these are the critical and non-critical, which I already mentioned. So depending on the day when the cyanosis is noticed, you have to suspect. If within the first 3 days, you have to suspect parallel circulations like transposition of great arteries, or critical obstructions like duct-dependent lesions, obstructed TAPVC, or critical Epstein. Beyond that first 3 days of life, that is when the PDA closes. Again, obstruction to systemic or pulmonary blood flow can become manifest. After 14 days, you have to suspect lesions which are dependent on fall in pulmonary vascular resistance and which present as mild cyanosis and mostly heart failure, and those are the admixture lesions. So if you keep this in mind, you can cut down your diagnosis to very few conditions. So how would you evaluate a cyanotic congenital heart disease? You have to take a proper history. When did the cyanosis start? What other history did the baby have? Was there any feeding difficulty? Was there respiratory distress? We have to be particularly careful about S2, but it is very difficult to assess S2 in the newborn period because of tachycardia. Some findings will give you a clue, but I agree it is very difficult in the newborn period. So if you have a wide fixed split like you had in this patient that you discussed, it could be a TAPVC. Mostly it is single S2 in most cyanotic congenital heart diseases, and you have it often in pulmonary atresia and transposition of great arteries. Of course, forelimb BP is extremely important. You also have to look at the situs of the newborn, and X-ray and ECG will give you valuable clues. So what are the other clues from your history and physical examination? If the baby has cyanosis but no respiratory distress, you should suspect duct-dependent pulmonary circulations or tetralogy of allophysiology. If there is cyanosis with significant respiratory distress, you have to suspect obstructed TAPVC, where the respiratory findings are as good as or even more than the cyanosis. So if there is differential cyanosis or uniform cyanosis with shock, obviously it is a duct-dependent systemic circulation. There is more predominantly heart failure with mild cyanosis, and this usually happens after the first 2 weeks of life. Then you are dealing with an admixture lesion like a truncus arteriosus, single ventricle, or a TAPVC. Heart failure with severe cyanosis. That is, there is mild heart failure, but the cyanosis is very severe. You are dealing with TGA. Cyanosis with stridor, it is very striking that you should consider tetralogy of Fallot with absent pulmonary valve. And any CCHT that presents with abnormal rhythm, you have to suspect Epstein's anomaly, left isomerism with associated defects, or a corrected TGA, VST with pulmonary stenosis. So these are the clues that you get based on murmurs. So most of them don't have any murmurs. Most of the critical cyanotic heart disease don't have any murmurs. That is something that you should keep in mind. So all your obstructive TAPVC, duct dependent pulmonary circulation, TGAs, they don't have murmur. You may have a short systolic murmur in a duct dependent pulmonary circulation or a systemic circulation where the duct is starting to close. You don't get a continuous murmur. Continuous murmurs are very rare. You have it if you have large collaterals and if you have a large PDA beyond the first 2 weeks of life. You have a typical to and fro seesaw murmur in a TOF with absent pulmonary valve. So if you look at this is the baby who came with mottling and uniform cyanosis. You see the work of breathing and you have that mottled shock appearance. So this is a duct dependent systemic circulation. If you then X-ray will give you some clues. So obviously this child has come with significant respiratory distress cyanosis, saturation of 75%, and obviously you're finding a ground glass appearance, and this is a diagnosis of had a diagnosis of obstructed TAPVC. Another baby, 1 day old, very bad saturation, saturating at 40%, single S2. There's hardly any murmur. So you see that there is cardiomegaly, there is increased pulmonary blood flow, but you're having a saturation of 40%, and almost always this is a TGA. You see the narrow pedicle as well. So almost always this X-ray indicates a TGA. 3-day-old, rapidly worsening cyanosis. So it is 3-day-old. That is the time when usually the PDA closes after the first 24 to 48 hours of life. Single S2, no murmur. You have very much reduced pulmonary blood flow with no cardiomegaly. You should suspect a duct-dependent pulmonary circulation. Anything with a pulmonary atresia. So this is a box-shaped heart. Usually we see it in tricuspid atresia. You see the RA enlargement and cardiomegaly. So this is a wall-to-wall heart, and if it is associated with cyanosis, you should suspect pulmonary atresia with intact ventricular septum or a critical Epstein. So these are the clues that you get from X-ray. You may not always catch a diagnosis, but you can narrow it down. ECG gives very limited value because most of the conditions cause right axis deviation with right ventricular hypertrophy. Like in your patient, that patient also had right axis deviation with right ventricular hypertrophy. But if you have a left axis deviation, you may be dealing with a tricuspid atresia or a pulmonary atresia with intact ventricular septum or a single ventricular left ventricular morphology or AV canal defect. So in this example, if you look at the limb leads, you are having a left axis deviation with poor right ventricular forces. So this is a tricuspid atresia. Now, like your patient, if you have an older child with cyanosis, how do you go about discussing them? So you first make out from your history whether you're dealing with a reduced pulmonary blood flow situation or an increased pulmonary blood flow situation. So if it is a reduced pulmonary blood flow situation, you will get a history of cyanosis soon after birth or early on in infancy. So what is this deferred cyanosis? The parents say that this baby was not blue immediately after birth, but as months passed, maybe after 1 or 2 months, they slowly started noticing mild cyanosis, which gradually seems to be increasing. So there are a lot of hypotheses about why this happens. It could be that it was a pink tetralogy of Fallot and the severity of pulmonary stenosis increased as the baby grew. It could be because the metabolic demands increase as the baby grows and then the baby manifests cyanosis more. Hemoglobin F is replaced by adult hemoglobin. There may have been a large PDA which have closed off or MAPCA which has become stenosed. So these are the causes of deferred cyanosis. Also, sometimes cyanosis may have a bimodal presentation, and that is typical in Epstein's anomaly. So you may have a cyanosis detected soon after birth when the right ventricle is incompetent to pump against the high PA pressure in the newborn period. So there is cyanosis because of AST shunting right to left. Slowly, the pulmonary vascular resistance comes down, the baby becomes pink, and after a few years, again, when there is RV dysfunction, later on, maybe after the child is a little bigger, again, child develops cyanosis. So that is a bimodal presentation. Also, you should ask for history of spells. You should ask for all spell and squatting variants to the parent. And once you have that history, you should think of a reduced pulmonary blood flow situation. And in these children, growth is primarily unaffected. So how do you know whether the child is having an increased pulmonary blood flow situation, cyanosis with increased pulmonary blood flow? So you have history of heart failure. That is why sir was repeatedly asking about recurrent LRI. So the mother will give history that the child was having failure to thrive initially with recurrent pneumonias, but then slowly the heart failure improved as the child developed pulmonary vascular disease. And cyanosis will be very minimal to begin with. And when the child develops pulmonary vascular occlusive disease, the cyanosis may intensify. So it may be so minimal that it may go undetected in the early periods. then of course the parents will say that heart failure symptoms have improved, but with worsening of cyanosis. Thank you.
That's wonderful.
Anupam?
Yeah, that was a great presentation, Dr. Deepa. Very nice and concise, but complete to the best of extent. So, very good description of all the differential diagnosis of different presentations at different ages of the child. Anything if somebody wants to ask?
Yeah.
And one clarification that catheter was multi-purpose catheter, which Dr. Gautam was showing. It was not JR catheter. And because angioburman is not available nowadays, and we could not, we actually entered the left atrium through PFO. So LA pressure was there, but somehow we were not able to get proper pressure from using multipurpose catheter. And so because LA and RE pressures mean we could not get in this child, and he was considered just at the cusp of operability. Surgeons were consulted and surgeons were ready to operate also. But at the last moment, family refused. They said, because when they were told about the surgical risk, they said, father said, no, his child is moving around and he's better off. So he would not like to take any risks. So they left, but surgeons were ready to operate upon this case.
Right. No. It is just to scare him a little bit. I think that's quite okay. So somebody is asking hypertensive PI versus absent pulmonary valve. So that's easy, you know, that can be done with stethoscope alone, because absent pulmonary valve is a normotensive PR, whereas a hypertensive PR is hypertensive PR. So hypertensive PR sounds like a AR. That means it begins after second heart sound, it is decrescendo and it is high pitched. Whereas a normotensive PR, as you can auscultate in post-op TOF patient who have normal P pressure, there is a second sound, there is a small gap, and there is a murmur which looks more like a mitral stenosis murmur. Most often, the first time the resident will diagnose this as MS. So this is a low-pitched PR murmur, which begins after second heart sound and a bit of a gap after second heart sound, where from it starts. So the two are quite different, as a dog is different from a cat. You see, if you hear them once, you will not miss it. And so therefore, the only diagnosis from stethoscope which you can do in a neonate is absent pulmonary valve with TOF, because there is a normotensive pulmonary regurgitation. Hope that is clear. Any other question from anybody for any of us, Simon? That was a wonderful review of cyanotic heart disease. I also got refreshed within say 10 minutes.
We have few comments. We have a cardiac surgeon with us. So Dr. Divya will say a few comments. Divya, you can just...
Yeah. Hi, good evening, everybody. So I was told it's a TAPVC case with the findings that the student has presented with features of borderline operability. I would agree with the surgeons which Madam has said in Patna. We would probably offer surgery for this child. And as Dr. Kothari mentioned, we would probably fenestrate the ASD, or if it's a small enough ASD, just leave it alone. But offering surgery at this age with the hemodynamics that was mentioned, I think we would go ahead and offer surgery for this child.
Right, I'll agree. The thresholds are a little higher, so maybe you could. But in real world, this often happens that parents are not willing and they take away the baby. Sometimes TAPVC come at 40 years of age and they are still operable. You must
true, sir.
Adult TOF, adult TAPVC, supracardiac in particular, and
yeah.
The thing is, if they have good ASD, they may often remain operable until very late.
Sometimes it happens, and also I think it's important to have a good setup where you have a good nitric oxide available or an ECMO backup, in which case you're able to give better results, obviously, than in a peripheral center where we may not be able to pull the child through.
Right. And then they are notorious to get PA crisis, especially when they are younger.
Right. Yeah.
That you should keep in mind, Gautam. That's for you. Lovely. So
Sir, a small thing, sir. So the moment we say that it's an admixture physiology and the patient is desaturated, our brain errs more towards inoperability. So would you still consider this child operable, sir? Because today in the OPD, I saw a 14-year-old child, coronary sinus TAPVC, TR-RVSP is somewhere 65. The
He
same
should be
thing.
operated. He should be operated. His aortic saturation is?
He is Sinosed club saturation is 78 in the OPD.
78 is slightly worrying, because if it is 85 plus, then I will know without hesitation say surgery.
Yes, sir.
60 is quite encouraging, 60 TR, maybe 70, 75 P of systolic. We can take a chance still, but we'll have to see the whole data. I mean, see the whole data.
Yes, sir.
But my guess is that probably will be operable.
Okay, we are doing a CAT, sir. I'll update you on that.
But
Thank
TAP
you.
is slightly different, we can't use the same analogy with other admixture. So you are right that the minute we see admixture, we are generally scared, and more often than not, they are operable. They are inoperable. More often than not, they are
Yes,
inoperable.
sir.
So I
Yes,
mean,
sir.
TAPC is one particular setting where we keep threshold little like that, but majority of them are inoperable. And Gautam, that operated thing is worse off. He will live longer without operation if he was inoperable. So either he can die
Yes,
during
sir.
surgery, or post-op his course will be bad enough. So if you are in doubt, don't operate like that. So operable is a proactive thing which must be done if there is a reason to do so. No, we don't take a chance and operate. If there is a reason to operate, then we do. And majority of the cyanotic admixture lesion by 10 years, 8 years will be inoperable.
Yes, sir. Thank you, sir.
So
Thank you, sir. It is enlightening.
So I thought, Gautam, did you learn something?
Yes, sir, surely, sir.
Thank God. So I hope they did learn something from all of us, this thing. The only other thing I have is I see more boys than girls in the chart. So I think the association can start charging the boys extra than the other ones, So this primarily WinCars, but there are more males in the chat box, in the I think people listening to. But it's a good thing. It's a good initiative, and thank you for this opportunity.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you so much.
Thank you.
Thank you. Thank you. My video is not working, so thank you, everyone.
Thank you, everyone. And my special thanks to the faculty, guest faculty, who made it very lively, and I learned a lot from the discussion today. Thank you, Dr. Gautam. It was a nice presentation. And thank you, everybody. Thank you, WinCars, for giving me the opportunity to convene these sessions. And thank you, everyone.